Welcome everybody to the fourth session in the Advances in Research and Innovation stream of SNOMED CT Expo 2023. My name is Rory Davidson. I am the Chief Information Officer at SNOMED International, and I'll be moderating today's session. All questions will be answered at the conclusion of the presentation. Online attendees, please use the Q&A button in the app to type your questions to the presenter. And anybody here in the room, please walk up to the mic beside the camera. I'm now very pleased to introduce Sophie Williams from Barts Health NHS Trust, who will be presenting the use of SNOMED CT knowledge graph to predict diabetic foot diagnosis from deeply phenotyped patients. Sophie, over to you.
Thanks, Rory. And yeah, brilliant to see so many of you in this last session before lunch, so very much appreciate that. So I'm going to tell you a bit about the project that we've been working on for a few years now, trying to predict diabetic foot disease in real-world data. And I've presented previously at these events about how we classify patients as having diabetic foot or not having diabetic foot. So this is kind of like the next stage of the project that I'll tell you about now. So first of all, my background's not clinical, but I'll tell you a little bit about the kind of use case that I've been tasked with at Barts Health. So we know that diabetes kind of can lead to lots of complications. And one of the complications we're really interested in is diabetic foot disease. And we know that patients who come into the hospital with diabetes often have kind of complex multimorbidity, really complicated previous medical history. And we want to understand what kind of combination of factors in the previous medical history means that they're most likely to go on to develop diabetic foot disease. We know that there's quite a high lifetime risk of developing a foot ulcer. And once a patient's developed one foot ulcer, they're more likely to have recurring foot ulcers. And these could get infected, and these infections might lead to amputations, which come with lower quality of life and increased mortality. So the kind of process that we're looking at is using free text notes, because we know that most clinical information is found in the free text, as much as we're trying to get clinical teams in the trust to do their SNOMED coding and put as much information as possible in structured form. At the moment, at least, most of the information is mainly found in the free text. So we want to kind of follow these pathways. So see when a patient comes in with diabetes, maybe then later on in their notes, they'll have a mention of neuropathy. We might pull out some social factors, such as that they work on their feet often, and then we might see that they get poor blood sugar control, and we want to see kind of from this timeline what makes them go on to start this progression of developing a diabetic foot disease. So no ChatGPT here, but we do use natural language processing to convert the unstructured patient notes into SNOMED coded information. So we use a commercial NLP tool from CliniThink, and they pull out post-coordinated SNOMED expressions that we can then query. So we can say, these are the kind of things we're interested in, pull those out, and then we can actually map those to pre-coordinated SNOMED concepts, which is a much easier data set to work with. A little description about the data set. So in this cohort that is being used for the analysis, there's around 40,000 patients with just diabetes, no diabetic foot disease, 12,000 with what we categorize as mild diabetic foot disease. So they're on the beginning of the kind of pathway towards diabetic foot. They might have kind of tenderness in their toe or pain in their foot. So there's lots of different things that we find in the free text that we can categorize as mild diabetic foot. And then severe diabetic foot is where they've kind of got these recurrent ulcers and they're very much on the pathway to requiring an amputation. And there's kind of 3,500 patients that fit that categorization. So the codes that we're interested in, there's over 1,000 unique SNOMED codes that have been pulled out of this free text. So they're the kind of features we can work with to do our predictive modeling. And patient concept pairs, so patient one has this SNOMED code. There's 770,000 of those. And this has been developed using about 14 million free text notes to pull out all this information. So the question once we have this data set has been, how do we use this rich but quite sparse data set in machine learning models? This is an example of kind of what the data set could look like. So the first column is just who's the patient. The second column is, do they fit the cohort of diabetic fit of interest? So that will be 1 if they do, 0 if they don't. And then you can see in this example that if a patient doesn't have any kind of renal disease, then although there's lots of really detailed kind of different SNOMED codes related to renal function, they would just all be zeros. So it's a very sparse data set, as kind of John mentioned earlier. So our question is really, how do we use these data sets in machine learning? And a first step towards kind of thinking about what to do has been taken looking at this graph on the right, which is just looking at the no diabetic foot and diabetic foot cohorts, looking at the top, I think, 15 concepts that have been pulled out of the SNOMED, out of the free text, sorry. What is their prevalence? And you can see that there's kind of different patterns between the two cohorts, which has kind of been taken as the first idea of maybe this is something we can delve into to try and kind of pull out the relevant features for our machine learning. And just to go into the kind of sparse data thing a bit more, so looking at descendants of kidney disease, there's over 1,000 concepts, which is really great. It's a really kind of well-established area of the SNOMED tree, but it means that you can end up with loads and loads of fairly similar concepts, which can be difficult to analyze. And we want to get the most detailed information out as possible. So we don't want to just kind of cut them all off and say, let's just take a really high parent concept. So the process has been to see how we can use the SNOMED knowledge graph to cluster similar concepts for using in machine learning. So let me just talk you through this diagram on the right, which is going to be kind of used to explain the process. So it's a diagram explaining the SNOMED knowledge graph, and each node is a SNOMED concept, and the number in each node is the number of patients in the data set who have mention of that concept or any of the child terms. So I'm going to kind of keep coming back to that. And now I want to present the SNOMED graph processor tool, which has been developed with Kai Cooley and myself to support dataset exploration and pre-processing for machine learning. And this is a data-driven approach. So we want to be able to compare datasets with a majority and minority class. The goal is to be as generalizable as possible. So in my use case, the majority class is diabetes without diabetic foot disease, and the minority class is where they do have diabetic foot disease. And because it's a data-driven approach, we're not relying on manually written code lists, which are quite often used in epidemiology and data science studies, where you have to sit down with an expert and say, pick out your 100 favorite SNOMED codes to describe heart disease, and that's all we're taking. And we're not using expression constraint language, which we could also say includes some sort of bias towards how we'd want to create the ECL queries. The goal is to create more independent features for using in machine learning. So if we included all of the nodes, then we know that there's a lot of relationships between the nodes, which luckily are captured within the knowledge graph, but can lead to lots of collinearity in modeling, and kind of they overlap a lot. So we want to kind of separate out features as much as possible. And crucially in medicine, we want explainable cluster groupings so that when I sit down with the clinical team, we can say, this is what the tool is doing. This is how we get to these conclusions. So we can really delve into why a model is predicting what it's predicting, which we find is the only way to kind of get people on board with what we're doing and start using our tools. And the goal of the SGP is to go from this quite complex, large number of nodes to this, which is the key 2 nodes to take forward into our model. So the way we've developed SGP is using a synthetic data set. That's because it's a lot easier to develop these tools where we know exactly what patterns are in the data that we want to pull out. Because if we go straight onto using in our real world data set, then it can pull out some quite wacky findings, and we don't know whether it's the logic in the tool doesn't make sense, or that just the real world data set has strange things in. So this synthetic data set is using a COVID data set, and the process for developing it is available on GitHub, and you can speak to Kai if you want to develop your own. It's a SNOMED coded data set that has patient SNOMED code pairings. And so that's one of the inputs. But the first step of the SGP is that we load in the relationships and descriptions of SNOMED. So that gets all of the knowledge graph. And then we want to enrich it with our patient data. So we have this sparse knowledge graph where we have the two patient groups. So the diabetes and the diabetic foot patient groups. And we know at each node which patients have information about at that node. So that's the enriched stage. Sorry, I had animations on these which disappeared, but that's fine. And then the next stage is infer. So once we've got our knowledge graphs for the majority class and the minority class, so we can see at each node how many patients per class have information at that node or any of the child terms. The way we do the processing is we look for basically the weighted difference between A and B. And that's because we want to see where there is a node that has the most information. So you can see in this area here, there's not a difference between the proportion of patients in group A and B that have information at that node or below. So it's just 0 is the weighted difference. So these are kind of things we can just drop. They're probably not going to be informative about who's getting diabetic foot. Whereas at the other nodes, we do have a weighted difference. Then the next stage is we add this boost, which is a configurable value. And that is kind of giving extra weighting to any nodes that are lower in the hierarchy. So the more granular information, which is the kind of information we'd want to pull out, gets a kind of boosted weighting. So they're more likely to be picked out as nodes of interest, because otherwise it's quite easy for the kind of higher up nodes to be pulled out, but that's not necessarily where the information we want to take forward is. So that's the infer stage, which comes up with a list of the boosted patient count difference for each node. And we can decide at that stage which ones have the highest difference between the majority and minority class. And then we'll take those out and say, okay, cool, we'll take these forwards to use in our machine learning model. And it's a looping cycle. So once one node's been taken out, then the loop starts again after this pruning stage. Oh, sorry. Which means that in this example, this node here has been taken out as one of the informative nodes. So then the prune tree removes this node in any child terms. So that then we relook at the boosted weighted difference between the majority and minority class to take the next node out. And we pull out, it's a configurable value, how many nodes we want to pull out to take forward to our predictive modeling stage. So we just report the top nodes, so the top boosted patient count difference nodes, and there's a list of banned nodes which can't be taken out, and these are the kind of more administrative terms that don't have any clinical meaning that we don't want to put into any models anymore, so they're quite high level things, so they won't be taken forwards. And so the output of the SGP tool is a list of the codes that have the highest weighted difference and a map of how to map from the input code, so our input data set, to this new data set that was created, which may be the original or it might be an enhanced code. So the next stage has been to, once we've kind of worked out how the logic works using the SGP and a synthetic data set and checked that the patterns which we've put into the synthetic data set are pulled out using the SGP, it was time to jump into the real world data and see kind of what we can find when running this on this NLP generated rich real world data set. So the method is generalizable. We can apply it to any different scenario, including other data sets. But then there is a very large jump onto real world data sets. So the question was, is real world data too noisy for signals to be extracted? And interestingly, I've been through this with the clinical team, and we're very interested in it. So the top predictive cluster that was pulled out was this disorder of thorax, and it is quite a big cluster. So we can see there's 90 SNOMED codes have been clustered to create this disorder of thorax, and it has the highest weighting. And we think that because this is a hospital data set, so people with diabetes coming into hospital are likely to have some sort of like chest pain, chest complaints, especially those who have more complications, who are more likely to have diabetic foot. It kind of makes sense that that would come out as quite a good prediction. Obviously, things like pain in lower limb, you'd hope would predict diabetic foot. And then something like altered bowel function, we're thinking it might be to do with their autonomic nervous system dysfunction, or it might be to do with the combination of painkillers that they're on. But you can see the only negative weighting prediction here is pregnancy, which is quite interesting because we know in our data set that there's a lot more males that have diabetic foot disease. So having a negative weighting means that it's less likely to predict diabetic foot. So that kind of fits the bill so far. But yeah, so it's a very good kind of initial way to explore the data set and talk through with the clinical teams to see if we think it makes sense. But then I guess the big question is, how does this help with machine learning models? So just as a kind of very baseline, we used a logistic regression and compared when a clinician selects their favorite predictions, predictive features of diabetic foot disease to those pulled out using the SGP. As this is a real world data set and very, very messy, our numbers are not super impressive, but I think you can see that there is an improvement with the SGP. And when we look at the clinician selected features, that includes some structured demographic information that isn't SNOMED coded, so can't be selected by the SGP. So in the kind of third grouping, we include both the clinician selected and the SGP selected features, and this does slightly improve the ROC compared to either alone. And you can see kind of hyperparameters chosen from a grid search. But I think that this is kind of the starting point. Obviously, there's a lot of different models that could be used. This is very much the most basic one. And the SGP gives us a good configurable way to delve into the data set and pull out these features where inputting over 1,000 really, really sparse features just isn't really that valuable. So to kind of summarize, we present new methods for using these large real world and NLP generated SNOMED coded data sets. And the SGP is a tool for clustering sparse data sets to extract the important but specific differentiators between data sets. And yeah, we're really interested in getting things as features as independent as possible for using machine learning models. So some of the next steps are obviously to use it as the feature extracting step for use with other machine learning models, but then also to explore with primary care scenarios. So it would have to be trialed within primary care data sets before being used there, but that's where we see these kind of tools being used in the future. And then if the prediction improves substantially from where it currently is, then we're looking at how we deploy these tools in the hospital, because the kind of first part of the project, the using NLP to identify diabetic foot patients, is something that's actually been taken into the hospital and is starting to be used by clinical teams, which is very exciting. So if you want to read more about the SGP than I can explain in 20 minutes and give it a go yourself, then the code is open on this GitHub page. And yeah, there's a README that I think has been updated recently. Hasn't. It will be updated very shortly. And yeah, it'd be really great if other people can give it a go on their data sets and see what they think. Even within Barts Health, we've got a few other kind of clinical scenarios where we want to give it a trial. So we want to make sure it is a very generalizable tool that's kind of suitable for lots of different data sets. So thank you for your attention. And yeah, just to highlight that Mr. Sandip Sarkar is our consultant vascular surgeon, who's given lots of clinical advice, and Charles and Kai in the room have contributed lots to this project as well. So thank you very much.
Thank you very much, Sophie. Sophie will now take questions. As a reminder, if you're in the room, please step up to the mic. At the moment, we have no online questions, so over to the room. Any questions?
Yeah, thank you. My question is about the NLP process. What can you say about, let's say, the sensitivity of your NLP and also the false positives or false negatives, for instance, false positives when it doesn't recognize negations, things like that. Have you checked it, and on which vocabulary does it rely?
Yeah, so we use a commercial tool produced by Clinithink. It's actually a rules-based system, so it's not one of these kind of really smart new GTP-based systems, but that for us is quite beneficial because it's very reliable. So we know that if something's been missed, then it will always be missed, but we can add a rule in and then it will be found from then on. We've gone through lots and lots of validation because it is being used now in a clinical scenario, and the accuracy, both sensitivity and specificity, are in the 90s. So it's got to a point where we're pretty happy with what it can do. And it's difficult because some of the things that are missed are our definition of diabetic foot can change. So the clinical teams can decide, oh, this is relevant. Oh, suddenly it's not relevant. So there's not a kind of baseline gold standard. But then also there are things like acronyms and typos that it can be difficult to work with. But the Clinithink tool, so it pulls out post-coordinated SNOMED expressions. So that does include negation, timing context, who the concept is related to. So is it the person who the note's about, or is it a family member, and certainty. And all of those can be built into the queries of the kind of information we want to pull out. So we can say we're only interested in certainty, we're interested in possible or definite diagnoses. And that we've been through about 5 rounds of validation and developing the queries for that. So we're pretty sure about the identifying diabetic foot and not diabetic foot disease patients, but it's all the comorbidity information, because there's more than 1,000 different comorbidities we're pulling out. It's kind of not feasible to go through that level of granularity for pulling those things out. So that's definitely one of the stages of the processing, means that the data set might not be the perfect data set. It's very real world. Charles.
Thanks. I'm not going to ask you a question, Sophie, so don't worry. Wouldn't be fair. But I think this has been a really great example of how to do validation and how to involve people, both in their understanding of SNOMED and their understanding of medicine. So quite a lot, I think, of Sophie's validation team have been junior doctors in training and medical students. And that's really, we found a whole bunch of medical students who then go, whoa, show me more, do this. And it's been a great experience in developing a sort of a body of people who are switching from old styles of thinking to the new styles of thinking.
Daniel? Yep, please come on to the microphone.
Daniel Carlson, Swedish Health Agency. I had a question about the SNOMED angle of this. So maybe that's 2 questions. So first is how did you actually use SNOMED in the cluster selection? And is every member of the cluster equally representative of the class, or did you consider something else?
can definitely answer the first one. I might need Kai's help for the second one. So the SNOMED relationships were built into the knowledge graph. That was the first thing set up. So we had the kind of parent-child relationships in there, but we didn't include the kind of like, is this what's the finding site? Those kind of relationships, to keep it simple for now. And because each node had, whether that concept was mentioned in the text or any child terms, then they were kind of clustered at that point anyway, if that makes sense. Kai will also go into more detail, I'm sure.
Yeah, I think so. Yeah.
Okay.
Can you rephrase the second question?
The second question, so each member of that cluster, were they equally representative? Like, were there some, if you had a question in the code, was it either a member of the cluster or not? Okay, so if you find something in the text that matches, was there always a 0 or 1 match, or were there some which were more or less representative of the meaning? Yeah. Okay.
Oh, it was about the NLP.
Yeah.
So yeah, we didn't look at like how many times a concept was mentioned. Is that what you're asking about? Like was, I don't know, like a headache mentioned all the time in the text versus just once? We just looked for a one-off. Has it been mentioned at some point? Is that your question? Sorry if we don't understand. We could have a chat afterwards.
Yeah, we could have that offline then. Okay,
Yeah.
thank you.
Okay, so with that, we'll conclude the session. Thank you very much, Sophie. Fascinating discussion. Thank you.